I just met a new friend this morning, Dr. Clark. He started his job while I was still here in Louisiana. He was an appointed member of the Louisiana Commission on Preventing Opioid Abuse and is the coroner for East Baton Rouge Parish, which is where I lived at the time. Dr. Clark's mission has been to engage his office fully in 3 jurisdictions: death investigation, mental health investigations, and sexual assault investigations. He's currently serving as the president for both the Louisiana State Coroners Association and the Louisiana State Medical Society. So thank you very much for being here.
Thank you so much. Can everybody hear me okay? All right. So like I said, I'm Dr. Beau Clark. I'm the East Baton Rouge Parish Coroner, and I'm happy to be with you this morning, and actually I'm talking first, which is very unusual for a coroner because we usually talk last. Oh, that's a coroner joke. Okay. All right. Tough crowd. I got it. Okay, so a little bit about my background. For about 10 years, between 2003, 2013, 14, I was assigned and participated as a sheriff's deputy with the East Baton Rouge Parish Sheriff's Office and their SWAT team. I'm what they call a door kicker. Has anybody heard that term before? A door kicker? So I had a responsibility to, when street-level narcotics agents would make a case, they would go to a judge, we'd get a warrant, and then they'd send the door kickers in. And we go into a house, we kick the door, we get the bad guys and the drugs. And that's what we did. We did it for 10 years. And I could tell you during that time frame, we took a lot of cocaine out of people's houses, and we took a lot of marijuana. Well, one thing I never saw was heroin. And the reason I tell you that story is because we're about to dive into what I call the story of heroin and how it happened, okay? And you'll see how that synergizes with what's going on in our opioid epidemic. So let's talk a little bit about heroin. We'll start. That's me last time I was seen not wearing a bow tie. Anyway, heroin is an opioid painkiller. There's the fancy name for it. It's a derivative of morphine. It's a recreational drug, meaning it has no medicinal purposes whatsoever, and people use it because they get high. It provides a euphoric effect. Its side effects, though, include CNS and respiratory depression. And if you depress your respiratory system enough and you stop breathing, what happens? You die. And that's what makes it dangerous. You can see in this picture to your left, it comes in various forms. It can be a brown powder. It can be a white powder. Sometimes it's a black-looking powder. They call that black tar heroin. But nonetheless, when we think about this in our mind, we think about a powdered substance, a needle, and a spoon. If you close your eyes and say, what is heroin, that's what you see. Postmortemly, however, we never find heroin in anybody's system. So when I draw your blood or urine after you've died and we check it through a laboratory, we find a drug called 6-monoacetylmorphine, or 6-MAM for short, and it's because heroin, once it enters your system, rapidly metabolizes into the 6-MAM. And that's what we're looking for. So when we find 6-MAM in your urine or blood, it tells me that your death is potentially related to the use of heroin. Okay? Real quickly, we got to understand 2 terms, potency and tolerance. Potency is the illicit response for a drug as it's prescribed. So, for example, if you take a 200 milligram Motrin, we know that there's going to be an effect related to the potency of that drug. Okay? And that is done through an FDA process that's done through the manufacturing of that pharmaceutical. How many times do you think heroin dealers go to the FDA and get their drugs tested? Whopping 0. Okay, all right? So if you're a heroin addict and you go to buy heroin on the street, do you know its potency? Absolutely not. It's not been tested. So it might be 0% potent, meaning it's not heroin at all. It might be low potent, like 10 or 12%. It might be very potent, like 50 and greater. All right? And as a user, you're going to use a set volume of that drug. And when you use a set volume of that drug and you don't know the potency, you get yourself into trouble. And that trouble is overdose and death. The second piece is tolerance, and we understand that when we talk about opioid prescriptions, your body can become tolerant to it. Everybody has heard the story of the person who said, yeah, I took a 5 milligram Lortab or Norco or whatever, and after a while that didn't work, so I had to take 2 of them. And after that didn't work, then I had to move from hydrocodone to oxycodone, and then oxycodone didn't work, and I had to get on fentanyl or some other really, really powerful opioid. That's because of tolerance. Your body creates a tolerance to the drug. So why do I tell you about these two terms is because they develop into 2 situations we commonly see with overdose, okay? One is instant death in the naive user, someone who's never, ever, ever used heroin before, okay? They've now made the transition from using prescription opiates. They're going to use illicit drugs like heroin or fentanyl, and they use it for the first time, and they don't know its potency, right? And they overdose as a result of it. That's the naive user. Very common. The second situation is when we see a person who has is a chronic user. They go into rehab. Their tolerance then lowers to a baseline as if they've had it before. They use the drug, and it's like being a naive user. They use it for the first time, excuse me, and they have instant death from respiratory depression. So those are the two situations. So here's the problem with heroin. So like I said, back in my day in law enforcement, never saw heroin. Become the coroner in 2012. I have 5 deaths in our parish that year from heroin. So I start scratching my head. Well, all of a sudden, do we have heroin in our community? It didn't exist before. We never found it on any of these drug raids, but all of a sudden, I got people dying from it. The following year, that number rose from 5 to 35, a 7-fold increase in heroin deaths. That's a problem. We knew we were in the midst of something. So these are the numbers for heroin in East Baton Rouge Parish. You can see 5, 35, 27, 41, 34, and an all-time high of 45 last year, okay? Now, those numbers may look low, they may look interesting to you, they kind of go up and down, but what I want to point out to you is when I add other drugs, mostly opioids, over the top, you can see how those numbers begin to climb. So we get to an all-time high of 111 overdoses related to opioids, whether they be heroin or non-heroin overdoses last year. Now, if you break down what's in the other drug categories in the blue, and you see this dip that occurred to 34 in 2016, that's where fentanyl showed up, okay? Fentanyl's part of that blue line that's above that. So all of a sudden, we went from illicit heroin on the street to now more illicit fentanyl on the street. But it creates the same problem because they're both opioid drugs. So you have to look at this and say, you never found heroin when you kicked the door, but now all of a sudden we're in the midst of an opioid/heroin epidemic. How did this happen? What is the why? And so in our analysis of the why, these are the things we found. In the early part of 2000, the Louisiana legislature was doing some prison reform, much like they're doing now, and they said we have too many people in jail that are serving life terms because they're non-violent drug offenders, meaning they sell Schedule I narcotics, okay? The law used to say if you sold a Schedule I narcotic, and in that schedule are things that are non-medicinal, like LSD, heroin's in that, marijuana's in that schedule. They say, and I know there's some debate, we're not here to debate medical marijuana, but the point is Schedule I narcotics, you got life in prison for distribution. And does anybody know what life in prison means in Louisiana? Life in prison. That's it. That's what it means. It means exactly what it says. You go to prison for life, okay? What we decided to do was, because they were worried we had too many non-violent drug offenders in jail, that we needed to reduce mandatory sentencing for those Schedule I narcotics. Well, what they forgot about was heroin was inserted in there. And I don't really think heroin is a non-violent drug offense, because I think at the end of a heroin sale is the potential for death, right? Okay, so it should be kind of carved out. But nonetheless, we went from life in prison all the way to the very bottom, 5 years, okay? And 5 years means 18 months, good behavior, parole, etc., okay? So we went from the top to the bottom. What did that do? That told all the drug dealers in the world that, hey, come to Louisiana and sell heroin. It's a great place. We put a big sign up and said, come to Louisiana. If you get in trouble, it's only going to be 5 years, no big deal. And then they showed up, okay? They showed up to sell their heroin. At the same time, in 2010, the state participated and invented, through the Louisiana Board of Pharmacy, a prescription monitoring program. We knew there was a lot of doctor shopping going on. You've heard these terms before, where people were out in the community looking at different doctors and grabbing these prescriptions, right? Sometimes they would use them, sometimes they would sell them. And the pill mills and all this stuff was happening. Well, the Board of Pharmacy was going to break down on that with the advent of the prescription monitoring program. And what did that do? It worked. Okay? All of a sudden, that plethora of opioid prescriptions that was floating around in the community that people were abusing dried up. And who was standing on the sideline in that scenario? The heroin dealer. They said, oh, well, look, you can't get your prescriptions anymore, but I got something right here for you. Okay? And I moved into your state because you've got weaker laws than other states did. Okay? You see how that works? All right. What else? We also invented this thing called the pain scale. You heard Dr. Gee speak about this morning, right? There are 4 vital signs, in my opinion, that are scientifically calculated. That is, what? Your temperature, your pulse, your respiratory rate, and your blood pressure. Those are all scientifically calculated. And then we decided, well, we need a 5th vital sign, right? And what's the 5th one? Your pain scale. And what is that? Completely subjective, right? I'll look at you and say, what's your pain? You say, it's a number, and then I react as a clinician. Like, okay, number 5, that gets you a dose of morphine or something, right? So completely made up. But here's the catch. Do you know who invented the fifth vital sign, the pain scale? Big Pharma, right? You know what Big Pharma sells? OxyContin. Wow, that's pretty interesting. So they convinced the federal government that we should have a fifth vital sign and that we should treat people's pain as related to the fifth vital sign. And oh, by the way, we have a drug that you can treat it with. It's called OxyContin. Okay? Right? Pretty scary stuff. Also involved in that was a plethora of what we call patient satisfaction scores. So how many clinicians do we have in the audience? Right? Everybody heard of patient satisfaction scores? Right? Okay? So for everybody else, a patient satisfaction score is much like when you go to a hotel and they say, how was your stay? And you list all these things, right? The pillow was soft and the bed was comfortable. And, you know, so they do the same thing in healthcare, right? They say, well, how was your visit to the ER, right? There was no blood on the wall. That's like good stuff, right? But they also said, well, how did they manage your pain? Did they address your pain? Okay? So now all of a sudden we've turned these questionnaires and these patient satisfaction scores in on, did you get high? That's what I read when I see that, right? Okay? And if you're an addict, that's what they're really asking you. And as a clinician, what am I forced to do? I want you to have good patient satisfaction scores, right? So I'm forced to do something about their satisfaction, which is not scientifically based. It's subjective. And that's a problem, okay? So we put all that together, and there's the patient satisfaction surveys, and we created the perfect storm in Louisiana, okay? Right? The perfect storm was what? We invited the heroin dealers. We cut down on the prescription drugs that we were handing out because of the prescription monitoring program, and we created things that were not really based in science on the treatment of pain. And we created the problem, all right? And that's what we collectively created the problem, okay? So, things I want to note before we go further into the discussion is understand this. Heroin dealers are rarely heroin users. That's important. Other drugs are not the same. Sometimes people that sell marijuana also use marijuana, and the same is for cocaine, okay? But heroin dealers typically don't use heroin. It's very rare. Why is that? I love donuts. I cannot own a donut shop, okay? Because you would come to my donut shop, and I'd be like, I don't have any donuts. I ate them all, right? Make sense? Okay? So that's what we're dealing with here. You have to understand that in this scenario, the heroin dealer is a business person. They're there to make money. They want to sell this drug. They want you to use it. And sometimes you come back and sometimes you don't. And they're not so much worried about that because they have an endless supply of people coming through the front door. So if somebody dies as a result of their overdose, it's not going to impact their business, okay? Because we have so many people. And you also have to remember that the person who is addicted, the patient in this scenario, is not only physically addicted to the medication, they're psychologically addicted to the medication. So if you're going to treat that patient, you got to treat them twofold. So let's talk about the bad guy, all right? These are the guys I used to go after. They're in the business to make money. They want to sell a product that's in high demand, which it is. They have a customer base that'll do anything to get the product. Those are the users and the addicts. They're looking for an environment with a high return on investment and minimal laws that make business risk averse. Does that sound like something you would read in an economics class? Right? Right? It does. And we're talking about drug dealers here. Okay? And obviously they have questionable ethics. The bad guys in Louisiana, guess what they used to sell? Cocaine. Guess what they sell now? Heroin and fentanyl and all these other stuff. So you know why? 2 reasons. They make more money doing it. Okay? And the second reason is the cartel, where they get the stuff from, makes them do it. All right? Does everybody remember the 1980s? I know there were some younger guys I saw girls standing up earlier, but 1980s hit show Miami Vice, right? Crockett and Tubbs, Miami there solving the world's problems with the Colombian cartel, and cocaine was king, as they say, okay? It's those same people that have changed their business model from the sale of cocaine and importing that into our country that are now bringing in these illicit opiates, okay? And they've also gotten very creative in their other forms of distribution. So like we said earlier, when you think in your mind, heroin, needle, spoon, etc., right? And you're thinking, my God, how could somebody actually make that jump from taking a pill to injecting themselves, right? Has any clinician had to give themselves a shot here? Or anybody had to do that? That's pretty tough, right? How do you convince yourself? Do you go on 2, tell yourself you're going to go on 3, but then go on 2, but it's really yourself, right? So that's a tough thing to do. So what they've done creatively, and we've discovered this, is they'll take heroin and press it into a pill. Take a pill press. Make it look and you know what they make it look like? They make it look like a hydrocodone, right? Because what's more expensive, heroin or hydrocodone? Hydrocodone is now, okay? Right? And if I convince you this is hydrocodone, then you'll pay more money for it maybe, right? Pretty unethical. But nonetheless, you don't necessarily have to make the jump from injection to injection. You can also make it to ingestion, taking a pill. You can smoke it, you can snort it. It comes in different forms. And so they've been very creative in that distribution model. So let's talk real quickly about the good guy. The good guy is the patient. These are all the people that have become addicted. These are the people that are users. They're our patients, and they're the ones that we got to fix. They need our help. Remember that they are in need of both psychological and physical treatment for their addiction. So let's talk about general solutions, because I hate to come in here and tell you all the bad news, right? The doom and gloom. But how can we fix that? Because that's really what we're really talking about today, right? Is how do we fix this problem, all right? So I'm going to give you the big view of how to fix the problem, and then we'll kind of break it down into smaller pieces. 3 things you got to do. Wow, you thinking, Dr. Clark, you said 3 things and we're done? Well, that's pretty good. This short list, right? I mean, my wife gives me a longer grocery list than 3 things, right? So 3 things we got to do. Number 1, illicit drugs, right? That's the DEA. That's the cartel. We got to get those out of the country. Yeah, absolutely. That cannot stop, okay? Because as long as the illicit drugs are there, people are going to use them, all right? And they're deadly. Number 2, all right? We have to be better prescribers. As a prescriber, as a clinician, I've got to watch what I prescribe. I've got to curtail my prescription habits because I don't want to create any new addicts. We got enough already. We don't need to create any more. And do we know who the addicts are? Can I look around the room and go, oh, that person, and that? I can't do that, right? So every time I write a narcotics prescription, I run the risk of that person that I wrote it for becoming addicted to it. And if I give them a bucket to go home with of hydrocodone, guess what? I made it pretty bad. I made a bad decision, a bad clinical decision. So the third part of it is we've got a large group of people that are in the middle. Those are our patients. Those are the people that are addicted, and they need treatment for their addiction. Okay? So those 3 things, we figure it out. We solve that. We solve this problem. So let's look specifically how we do that. It is complicated. I'm not going to say it's easy. There's a lot of pieces and parts to it. But what can we do? Simple things. How about we stop using the pain scale? How about this? I'm a clinician. I walk in and say, hey, I'm Dr. Clark. I'm here to see you today. What brings you in? I've got ankle pain. Okay, good. Well, you've got pain. What's my job? Treat your pain. We don't need to talk about what number, if it's a smiley face or a frowny face or any of that stuff, right? We have a relationship between the patient and the doctor in the treatment of their pain, right? What are our options for treating that pain, right? A couple, right? Could be anti-inflammatories. Could be elevation. Could be a little ice on your ankle, right? Sometimes it might be a pain if it's broken. Maybe you do need an opioid, but maybe you need a small prescription of opioids, like just a day or 2. Okay, all right. There's another thing out there, right, which is called just suck it up, buttercup, right? You can use that as well, right? Has everybody experienced pain in the room? Some form, right? You get out of bed and something hurts, right? And then by the time you walk 2 steps, you're good. All right? So you don't always need something for your pain. All right? So you have to have that conversation, though, obviously. Education and prevention are good things. Managing the bad guy, okay? Managing the bad guy. Remember, heroin users and heroin dealers, 2 different people, okay? So manage the bad guy and manage the cartel, all right? Recently in Louisiana, this was last year, Act 82 and Act 76 by the 2, the representative and the senator there, was a effort to curtail prescribing in the state of Louisiana. Essentially, what the 2 bills did that are now laws said the following: as a prescriber, I am not allowed to write more than 7 days of an opioid prescription for the treatment of acute pain. Okay, I think 7 days was a little long, but that's what we negotiated. Probably 3 would have been the appropriate number. But anyway, that was the first part of it. The other part of it says if I go more than 7 days, I got to explain to you as a clinician why. And I also have to document why, and I also have to run your name through the prescription monitoring program if I do so, okay? The last piece was the continuing medical education piece you heard about this morning. We're all required within the next year and a half, essentially at this point through 2019. I know Dr. Collada is here. You may talk about this later. 2019 mandatory CME for prescribers, okay? And I use the word prescribers because that's very important. It's not just about doctors, because guess who else writes prescriptions? Dentists do, right? other levels of the healthcare providing system, such as nurse practitioners, et cetera, that have prescriptive authority. So it's all prescribers have to be responsible for this. And lastly, how do you treat the addict? You treat the addict twofold. You got to treat them psychologically through medically assisted through cognitive behavioral therapy, working on their mind, and of course, remember their physical addiction. You have to treat with medically assisted treatment, and that's tough. You know why that's tough? It's tough because that's what costs the most money, right, to treat these people. Because we don't know how long somebody has to be in therapy. It's not like you can show up one day and I'm getting buzzed out here. You can show up one day and take a pill and then your addiction's over. Sometimes for these people, it's a lifetime. It's a lifetime problem. It has to be solved that way. So, all right, there's some references. I have questions and answers after that, but I know we have a panel, so I'll leave you with that. Thank you so much for having me today.